Namaskar, good evening all. Thyroid case management under the regional anesthesia is a long cherished dream of everyone every anesthesiologist in the view of ever growing demand for the better understanding of this intricate subject. I am happy to announce this webinar on the SAPC's Foundation Day, which was founded on the 11th December 2011. Myself, Dr. Shobha Ashok Vatkar, the President of Society of Anesthesia Pimpri Chinchwad, appreciate this webinar as a concise presentation of the wide range of thyroid case management components. The goal of the speakers in this webinar is to motivate the youngsters for the remote and limited access areas to do such cases under the regional techniques. I appreciate the depth and knowledge of the speakers to integrate the concern in this field into the wide range of practices. This is a vital art in which the contribution to the decision making is in this esteemed profession. I am humbled by their affirmation and the important concept in the field of anesthesia. The role of ultrasound may be added in this presentation in future. My sincere thanks to and gratitude to Dr. Bhau Rajurkar, Dr. Vivek Deshmukh, Manisha Zapate, Dr. Mugdha Markande, Dr. Maya Bhalera, Bhavesh Sheth, Sumit Lad, Dr. Balaji Asekaukar, SAMS officials, Geneca Technology support by Mr. Abhijit, Ganesh, and many more for constantly driving me to come out with this current webinar. I thank you all and welcome for the today's important thyroid session. Over to you, Madam Markandeya. Dr. Markandeya, please.
मॅडम तुम्हाला अनम्यूट करावं लागेल. मार्कंडे मॅडम
अनम्यूट करा मॅडम, अनम्यूट करा.
येस
Hello.
हा
Hello.
यू आर ऑडिबल नाउ मॅडम.
Thank you, madam, for giving me the opportunity to moderate this session. Our first speaker is Dr. Rajurkar. He is a renowned anesthetist from Nagpur. Since 1982, he was lecturer in GMC Nagpur. Then from 83 to 2006, he was freelancer consultant. In 2006, he was founder and director of 100-bedded multi-super specialty Gateway Hospital in Nagpur. Currently, he is the chief of anesthesia and pain medicine in the same hospital. Then he has received Lifetime Achievement Award and President Appreciation Award. He is past President ISA NCP, Geriatric Society of India Vidarbha chapter, and ISA for Study of Pain Nagpur branch. Then he was governing council member, Maharashtra State ISA. He initiated the renal transplant program in Nagpur and has 400 renal transplants to his credit. He presented papers on dual epidural for transthoracic esophagectomy and on thoracic epidural in pediatrics. He presented a series of 877 pediatric and neonatal epidurals. His special area of interest is epidurals in neonates and pediatrics. Over to Dr. Rajurkar.
Madam, would you start your video, madam? Your video is not on. Markande, madam.
Yes. Now I am visible.
Yes, madam. Okay. Go ahead.
So over to Dr. Rajurkar.
Where is my screen now? I cannot share my screen. Any technical glitch?
Ganesh, can you share sir screen, please?
मला पाठवावं लागेल तुम्हाला पीपीटी.
नाही बाकीच्या सगळ्यांचे बंद आहेत ना. एव्हरीबडी स्टॉप शेअरिंग. देन
सर्वांचं स्टॉप आहे. सर करू शकतात.
एक चालू आहे का स्क्रीन ऑलरेडी?
नाही सर, नाही.
सर
तिथं ग्रीन
सर
कलर मध्ये सर
शेअर स्क्रीन करा.
स्क्रीन करा सर.
शेअर स्क्रीन मी प्रेस करतोय ना.
हा सर येत
होतंय सर, होतंय.
येस येस.
माझं प्रेझेंटेशन कुठे आहे?
This is your computer.
पहिल्या स्लाइड वर जा.
तर राईट साइडला फर्स्ट आहे मला वाटतं. जस्ट मूव युअर कर्सर टू लिटिल बिट ऑन द राईट. We can see
नहीं,
renal anesthesia in thyroid.
cannot get it.
हम्म.
Just now I shared
ती
this screen.
स्लाइड ओपन करा ना सर. रिजनल अनेस्थेसिया इन थायरॉइड सर्जरी.
हाँ.
यस
हाँ ते ओपन करायला लागेल. हाँ.
Right.
Yes.
हम्म.
यस सर.
Yeah, we are able to see, sir. Thank you.
Why there is a table over there on my screen?
Sir,
काय
we
सर?
can see nicely, no problem. So you have to
But
just scroll to the next
seeing a
slide.
table over there because it is blocking my view to the words. Okay, I continue. Okay, thanks, madam, for your kind words, and good evening, all my friends. And at the outset, I thank Society of Anesthesiologists, Pimpri Chinchwad, for offering me this chance and opportunity to talk on the cervical epidural anesthesia as a sole anesthesia modality for thyroid surgery. And I will mainly focus on the basics and some fundamental issues and technique of cervical epidural anesthesia, and briefly share my experiences of cervical epidural anesthesia at Bhamragarh surgical camp. And this surgical camp, incidentally, is celebrating their 50 years of their this thing. So Dr. Maya was there last year. Probably this year also I expect
Yes,
her
sir.
to be here.
Yes,
And
yes.
this Biradari Prakalpa, this is of Lok Biradari Prakalpa run by Dr. Padma Shri Prakash Bhau Amte. And I am visiting this camp and the surgical camp for last 22 years. I got my own certain experiences about the cervical, how I started cervical epidural over there. And now you all know thyroidectomy is the most common endocrine surgical procedure being carried out throughout the world. And the standard anesthesia technique, all of us, we employed these techniques, involve the use of general anesthesia. But over the past decade or so, there has been a renewed interest in the regional anesthesia, partly because of advancement in the area of imaging. I am audible? Okay. Yeah.
Yes.
And development of expertise in various epidurals by anesthesiologists now. Now, these techniques are really useful in patients who are unsuitable for general anesthesia or in a low resource centers or surgical camp setting. Just now, I talked about that surgical camp. Now, friends, I am practicing cervical epidural either alone or in combination with general anesthesia for thyroid or breast or upper thoracic surgeries since last 2 decades. And I find it a very useful technique for a variety of reasons. Now, I have enumerated a few of the anesthesia challenges encountered during any thyroid surgery, but as a matter of fact, one thing remains clear that, and it is very fundamental that to ensure patients are clinically and chemically euthyroid prior to posting for any elective surgery. And also emphasis is given to the assessment of any potential difficult airway management, especially in a retrosternal goiter or a large size goiter of long duration. I would therefore like to recommend that cervical epidural anesthesia be undertaken in patients with good airways, and that could be easily secured in an emergent situation. Remaining are also real threats, either pre, intra, or post-op period, and should be addressed carefully. And obviously, cervical epidural is a challenging technique, and only experienced anesthesiologists should try it. We all know those advantages by epidural, and the same applies to thyroid surgery also. It provides high quality analgesia and can be used as a sole anesthesia, avoiding polypharmacy altogether. So GA is out of question when we are using cervical epidural as a sole anesthetic. And you need to block only segments required for surgery. You calculate the dermatomes and give only block only those dermatomes, sparing others, so that other sympathetics are spared with resultant good cardiorespiratory stability. And obviously, there is minimal bleeding at the surgical site because of vasodilation, and that facilitates surgery. Patient almost remains conscious, although he may be sedated a little bit, but he is conscious, allowing intraoperative voice monitoring. And with good anesthesia and postoperative recovery, patient can be ambulated early and with early discharge, reducing the cost of the patient. Few words about nerve supply of the thyroid. Nerve supply of the thyroid is derived from the cervical plexus on both sides, and it supplies sensory and motor innervation to the part of the head, neck, and upper trunk, and is formed by ventral rami of cervical spinal nerves from C1 to C4. Broadly, cervical plexus is identified as two separate plexuses, one superficial and the other deep. And superficial cervical plexus innervates anterolateral part of the neck through four distinct nerves: the lesser occipital nerve, great auricular nerve, transverse cervical nerve. And this transverse cervical nerve is primarily, it innervates the thyroid gland parenchyma. And the other is supraclavicular nerve. Deep cervical plexus contains motor branches and include ansa cervicalis, which supplies infrared muscles, and the phrenic nerve supplies that, and you all know. So having understood the nerve supply of the neck, dermatomal distribution for the thyroid surgery would be C2 to C5. I'll talk something about cervical epidural space. So you all know this, but just to refreshen the memories, cervical space, epidural space is a very narrow space and extends from the base of the skull to the lower border of C7. And posterolaterally, it is bound by thin lamines and then pedicles and intervertebral foramina, and contains fat and dural sac, some areolar tissue, lymphatics, colorless veins, and emerging nerve roots. It is a narrow space with a width of just 3-4 millimeter. And as you go high up, it gets narrow. And skin to epidural space distance varies from 5 to 6 centimeter at C6, 7 and 7T1, depending on the build of the patient. And all upper spaces, they are very narrow. Epidural space is narrow. Skin to epidural distance may vary from 5 to 6 centimeters. And another important thing is that spinal cord is enlarged at this level because of going to the emergence of brachial plexus. I cannot move further. Hello?
Ganesh?
Hello?
हॅलो
सरांची स्लाइड पुढे जाते.
Freeze झाला इथे स्क्रीन.
तिकडनं प्रॉब्लेम आहे सर तो त्यांच्या स्क्रीनचा.
माझ्याकडून प्रॉब्लेम आहे.
येस सर येस.
तर एस्केप दाबून
सर एकदा एस्केप दाबून परत प्ले करून बघा ना.
Is also not working. Just a second.
सर एकदा स्टॉप करून परत प्ले करा.
There is no cursor even. I cannot stop it.
Dr. Paliwal says, please enter. That's all.
No, it's a shutdown button. I mean, screen sharing stop करून परत करा sir.
I'm trying to shut it down, but cursor is not moving.
There's already the shutdown वरती आहे सर, तुम्ही just enter press करा की shutdown होऊन जाईल.
तर कॉम्प्युटरच बंद होऊन
Let's
जाईल.
say computer shutdown होईल.
हाँ computer सर.
तर करतोय मी पण काहीच होत नाहीये.
तर स्लाइड असेल तर माझ्याकडे पाठवा, मी प्रेझेंट करतो.
काय ते प्रेझेंट काही व्हिडिओज आता समोर माझे बरेच लॉंग व्हिडिओज आहेत, तेवढं पाठवणं डिफिकल्ट जाईल मला. जस्ट ट्राय. Shall I interrupt here and find out what is the problem with my laptop?
No, it's done sir. Stop sharing झालंय. Now you can reshare.
I think we'll wait couple of minutes, otherwise we can start with Vivek's presentation.
Yeah.
He's got a lot of videos that is to be seen actually. I think if people are interested in seeing the videos.
No, we will see that, but only for the time being.
For a time, let's see. Let's wait for a minute or so. Let the Ganesh solve this problem on his level. So we can see his PPT. Yeah, next.
तर आता विजिबल आहे.
Hello, sir.
येस मॅडम, दिसतंय मॅडम, स्लाइड दिसतंय ना.
तिथून गणेश सरांना म्यूट म्हणजे अनम्यूट कर बरं, त्यांचा आवाज म्यूट झालाय तिथे.
ओके. मी केलंय मॅम, इकडनं अनम्यूट केलं.
अनम्यूट केलं ना.
हाँ, now we can hear it.
हा या तसंच मॅडम त्याला व्हिडिओ स्टार्ट करायला सांगा ना. मी ऐकू येतोय का माझं?
हो
Yes,
सर,
या
yes,
सर.
sir.
गो अहेड, गो अहेड. येस सर.
आणि माझा व्हिडिओ नाही दिसत आहे ना. आय एम नॉट विजिबल ऑन द स्क्रीन.
हा गणेश सरांचं व्हिडिओ पण
गॅलरी मध्ये सर दिसत नाहीयेत.
ऑन.
तर व्हिडिओ तो साईज जास्त असल्यामुळे सर
तो व्हिडिओ नाही सरांचं व्ह्यू ते सर
माझा
दिसत
व्हिडिओ
नाही.
माझा
ओके
व्हिडिओ
ओके.
गॅलरी मध्ये साइड बाय साइड.
केलंय सर. ओके.
येस
येस.
येस विजिबल.
परत तेच झालाय प्रॉब्लेम बाप.
Sir, you can just go ahead. Like we can see your slide better, so we'll hear you. Okay.
नाही पण आता परत तोच प्रॉब्लेम झाला जो अर्लियर प्रॉब्लेम आलेला आहे.
नेट वगैरे व्यवस्थित आहे का सर?
हा नेट तर व्यवस्थित आहे. वायफाय ऍक्च्युली.
सर तुम्ही दिसताय गॅलरी व्ह्यू मध्ये, आम्हाला दिसताय सर.
हो मी तुम्हाला बघू शकतोय ना मॅडम.
हा.
तुम्हाला बघू शकतोय पण माझं
Slide.
प्रेझेंटेशन समोर जात नाहीये. फॉर सम रिझन आय डोंट नो.
सर प्रेझेंटेशन मध्ये व्हिडिओ आहेत का?
हो हो.
व्हिडिओ समोर आहेत.
हो सर ते सिस्टमचं हँग होतो त्यामुळे बहुतेक सर. त्यामुळे
माझं
पुढे जात
माझ्याकडून
नाही.
तुमच्याकडून होत आहे काय? कारण
नाही सर.
माझ्याकडून आतापर्यंत मला असा प्रॉब्लेम नाही आला कधी.
सर आमच्याकडनं नाही होत आहे, इकडनं तुमच्या सिस्टम कडनं येते ना सर.
ते सेपरेटली व्हिडिओ प्ले नाही करू शकत आपण.
दुसरं
करता
काही
येईल
ऑल्टरनेट
मॅडम, करता येईल.
हा
कसं?
तसं सेपरेटली व्हिडिओ प्ले कर. आता प्रेझेंटेशन मध्ये यू गो टू नेक्स्ट स्लाइड आणि देन यू प्रेझेंट सेपरेटली व्हिडिओ ऍट द लास्ट.
नाही 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 तो तसा प्रॉब्लेम नाही. आय कॅनॉट मूव्ह स्लाइड इव्हन आता ही जी स्लाइड आहे डर्मेटोमल डिस्ट्रीब्युशनची याच्या नंतरच्या स्लाइडवर मी जाऊ शकत नाही.
तर ते प्रेझेंटेशन क्लोज करून परत एकदा स्टार्ट करा प्रेझेंटेशन.
मगाच्या सारखंच परत मला ऑफ करावं लागेल कम्प्युटर.
नाही सर, ऑफ करायची गरज नाही ना. प्रेझेंटेशन तुम्ही क्लोज करा.
नाही क्लोज
आणि
होत आहे ना कारण माझ्या याच्यावर फुल स्क्रीन आहे. इथे सगळे ऑप्शन्स माझे हे झालेले आहेत, फ्रीज झालेले आहेत. आलं का लक्षात?
सर मला पाठवता का प्रेझेंटेशन? मी करून बघतो इकडनं.
ते मोठे म्हणतात स्लाइड.
हा मला वाटतं मी पाठवतो तोपर्यंत मला वाटतं पण दुसऱ्या लेक्चर नाही का?
हा बोला.
It is paused. आता दिसतंय का?
तर सेम स्लाइड आहे डर्मेटोमल डिस्ट्रीब्युशन.
हा आता ही स्लाइड मी चेंज केली दिसते.
नो सर हँगच आहे मला.
ही स्लाइड नाही दिसत आहे.
हॅलो
हा मॅडम.
सर तुम्ही म्यूट करा.
Not move my slides. I don't know.
आय थिंक टिल देन सर तुम्ही त्या स्लाइड तुमचं प्रेझेंटेशन शेअर करा. आय मीन त्यांच्याकडे आल्यावर ही विल शेअर, गणेश विल शेअर. आपण दुसरं स्टार्ट करूया का?
Yes, we'll start another presentation. Dr. Rajurkar, you may send to Ganesh by mail. Meantime, we'll and the technical problem may resolve. I think you have to give some time. Markandeya madam, please go ahead. Introduce Dr. Vivek now.
Okay. Our next speaker is Dr. Vivek Deshmukh. He is director and pain management consultant at his own pain clinic in Pune. And he is attached to Jahangir Hospital, Hardikar Hospital, and Dhanvantari Hospital as anesthesiologist and pain management consultant. And he has received Dhanvantari Award for Excellence in Medicine. And his achievement is he has developed and designed unique peripheral nerve locator and unique AI-enabled ventilatory mode. He has international journal publications to his credit. Then his special interests are 3D CT guided pain management interventional procedures like trigeminal, spinopalatal, and celiac plexus blocks. So over to Dr. Vivek.
Thank you, ma'am. Thank you for such kind introduction. Can you share my screen, please, Ganesh? Thank you, SAPC, for giving me this opportunity. I am feeling like I'm home, though I'm practicing in Pune, but I always feel that I am from PCMC, SAPC. So, um, starting with the thyroid surgeries under regional anesthesia. So, my main topic will be is regional, that too particularly superficial and deep cervical plexus blocks. Next slide, please. So usually wherever there is nerve, we can block those nerve. This is usual idea of anesthesiologist. This applies to the pain management also. But looking at the
We are not able to hear Vivek.
मे बी कॉल आला असेल सर त्यांना.
यायला लागलं गणेशला म्हणून.
हँग झालाय विवेकचं थोडं.
छे काय चाललंय बेबी.
गणेश, वेर आर यू?
मॅडम इकडनं प्रॉपर आहे सर, लेफ्ट झाले बहुतेक.
What is happening? हॅलो.
येस मॅडम.
कॉल कर.
हा गणेश, हँग होतोय सरांचा व्हिडिओ.
नाही ना मॅडम, मी इकडनं लावलंय तर ओके चालू आहे आणि सरांचंच प्रेझेंट नाही होत. सर प्रेझेंट नाही मीटिंग मध्ये.
जात नाही सर.
ओके ओके. त्याचा लॅपटॉप आहे सडनली बंद पडलाय, तो चालू करत 1-2 मिनिट. ओके.
Hello, Vatkar madam. Vatkar madam, can we take Manisha's presentation now?
She said unless and until he shows, she cannot go ahead, something like that.
Okay. राजूरकर सर, मग आपण नाहीतर मग वी कॅन डिस्कस ऑन प्रॅक्टिकल पॉइंट ऑफ व्ह्यू असं करूया मग. इफ प्रेझेंटेशन इज नॉट मुव्हिंग, सम टेक्निकल
नाही,
इश्यूज
माझं प्रेझेंटेशन मी आता मोबाईलवर आलोय. मी लॅपटॉप सोडलाय, मी मोबाईलवर आलो. जर गणेश करू शकत असेल तर आय कॅन शेअर माय स्क्रीन.
हा हा. पण सर मोबाईल वरनं तुम्ही प्रेझेंटेशन कसं करू शकणार? मग गणेशला करावं लागेल ते.
नाही, माझ्या मोबाईलवर आहे प्रेझेंटेशन.
अरे
ओके ओके. सर करून बघता एकदा?
मी
करून
करून
बघताय?
बघतोय, एकदा करून
हा
बघतोय.
हा. येस येस.
हे म्हणते यू कॅनॉट स्टार्ट स्क्रीन शेअर वाईल द अदर पार्टिसिपंट इज शेअरिंग. तर आधी ते
शेअरिंग. हा
शेअर बंद करावं लागेल.
स्टॉप
हा.
केलंय सर, मी स्टॉप
गणेश,
केलंय.
हा गणेश प्लीज स्टॉप द
येस मॅडम, येस
स्क्रीन
केलंय,
ऑफ
स्टॉप
डॉक्टर
केलंय.
विवेक. हा हा.
हा.
Ganesh, is this a technical problem from your side?
नो मॅडम, नो.
Vivek is
आमच्या साईडनं काहीच नाही मॅडम, सगळं प्रॉपर आहे.
I think Vivek is available now.
Vivek is joined.
थांबा थांबा, आपण
Vivek had
आता
joined.
राजूकर सर करत होते.
मी शेअर करतोय मोबाईल वरून. गणेश,
हो
मला
करा
थोडं
सर,
सांगा
करा.
काय करायचंय.
सर शेअर स्क्रीन वर गेले का?
शेअर करतोय मी.
अगोदर सर पीपीटी ओपन करून ठेवा.
अच्छा, एक सेकंड. हा, जस्ट होल्ड करा. हा, पीपीटी ओपन केलाय.
देन शेअर स्क्रीन, परत झूम मध्ये या आणि शेअर स्क्रीन करा सर.
थांब एक मिनिट. एक सेकंड.
हो.
हा, आता काय करायचं म्हटलं?
शेअर स्क्रीन करा सर.
आता स्क्रीन शेअर करू?
हो हो.
अच्छा, ठीक आहे.
आणि ती स्क्रीन सिलेक्ट करा सर. तुम्ही जे पीपीटी ओपन केली ना,
स्क्रीन शेअर केली आणि स्टार्ट ब्रॉडकास्ट म्हटलंय.
करा ना सर.
ठीक आहे.
हा.
ओके, चालू झालंय सर. आता पीपीटी ओपन करा सर.
आता पीपीटी ओपन करू?
येस येस. हा, साईडला गेले सर. हा,
आता ठीक आहे.
येस येस, आता दिसतंय.
येस
आले.
ओके सर. ओके ओके.
हा, जात आहे, पुढे जात आहे.
थोड्यामध्ये काही हे राहतील, मोबाईल वरून करते त्यामुळे.
Okay, okay. We can at least see and hear you, and it is moving now.
Yeah, probably I was here. Did I talk about this ligamentum plan?
No.
No,
No,
sir.
sir. Before
Earlier
that.
slide.
I
Earlier.
start from here then. Okay. So, friends, sorry for that technical glitch. And now I move on. Uh, Ligamentum flam, also called as a yellow ligament, it is thinnest in cervical area with thickness of 1.5 to 3 millimeter. And in lumbar and thoracic area, it is a little thicker. And the other thing is, it may not be fused in the midline in cervical area. And this particular point should be taken care of because you may not get that tactile touch of piercing ligamentum flam in cervical area in many patients. And any space, any intervertebral space, ligamentum flam is thicker caudally than cephalad. So our attempt should be try to hit the caudal part of the ligamentum flam. Then see, thoracic space, epidural space pressure is minus 15 centimeters of water at thoracic level. And this is more pronounced in sitting position. While in lumbar epidural space, pressure is not that obvious, it is minimal. So hanging drop technique or loss of resistance techniques are applicable in thoracic and lumbar epidural techniques. But whereas in cervical and for that matter sacral epidural space, pressure is not detectable. That is the reason hanging drop technique may not be successful, or that it will not ensure that you are in the epidural space. But loss of resistance technique is definitely better, I think, in cervical area. And this is my routine practice. I use only loss of resistance technique. I don't use hanging drop technique. Now here is a word of caution because of the presence of spinal cord, cervical cord enlargements at this level, and thinned out ligamentum flam. It demands high degree of technical proficiency. And in fact, the great Bromage decades ago, he has said that operators should have done at least 50 consecutive lumbar epidurals without a dural puncture before performing thoracic epidural, or for that matter, cervical. So now I say they should not try cervical epidural. Uh, at least they should have done lumbar epidural or thoracic epidural before they put their hand on cervical epidural. Now, pre-anesthetic check for any other patient, we do like that. Pre-anesthetic examination is done. Comorbidities are noted. All investigations, ECG, all those things are noted. And airway assessment is very important in these patients. Neck movements are seen, extension, flexion. Aerogram of this neck that will give you idea about compression and deviation of trachea. Now, this X-ray shows, see, compression over the trachea, and it has gone laterally, right laterally, it has moved away from the midline. So that is a very important this thing investigation, aerogram of neck. Then landmarks are, as I have told you about landmarks. Landmarks are noted and their dermatomal mapping is done. And then again, IV line is secured. All these cervical epidural, what I do in sitting position. Although lateral position, even prone positions are described, but sitting position is very comfortable to the patient and as well as to the anesthetist. Patient should comfortably on the stool with his head or her head on resting on the operation table, or patient should sit on the table itself, operation table, and she should be supported by someone. Because I tell you why I prefer a patient sitting on the table. During cervical epidural, excessive flexion of the neck, it causes vasovagal. Patient becomes little uncomfortable and then patient collapses. So it is readily he can be recited on the table, not on the stool. So I usually uh, ask patient to sit on the table itself, and patient is supported by someone. Then again, landmarks are identified and space between C7 and T1 is marked. And this is the only space one should hit. You should not go higher up because space gets narrower. And there is likely risk of hitting the, puncturing the dura or hitting the cervical cord, which is very dangerous. Then again, monitoring routine, O2 on mask is attached, emergency trolley, and then means of intubation and ventilation. All these things are kept ready. Am I audible now?
Yes, yes, sir. Go ahead.
Yes. So area is sterilized and draped, and then local infiltration with 1% lidocaine is done at C71 in a fan-like manner. You go straight, then inject at the interspinous space, come up, then incline the needle upward, go cephalad, and then go caudal. Because at times you need multiple needle punctures, so patient should not get discomfort hitting a non-anesthetized area. I have written IV atropine or glyco mandatory. It is absolutely mandatory to give IV atropine or glyco, because majority of patients, they get vasovagal because of excessive stretching of neck ligaments, neck muscles ligaments. And anxious patient, they should be given mild sedation. See, 16 gauge epidural needle, usually I prefer with bevel facing upwards. Then I hit the skin perpendicularly and then go bit by bit. And once you are in the interspinal space, airfield syringe is attached. And then again, it is moved bit by bit. Now look at my hand's position. That is a bromage position of hand. Your hand is resting on patient's back with a firm grip on needle's heart. Now see, I have actually identified the space. I'm not injecting air. Mind it. I'm not injecting air. I'm just getting that tactile sensation. And then obviously this dose should be given and then followed with full dose. Here I want to tell that I usually give full dose prior to catheterization. The idea is space gets a little bit voluminous, so it is easier to thread the catheter. And at least you are ensured that one dose is given to the patient, even if your catheter goes anterior in the anterior epidural space or into the intervertebral foramen or somewhere else. So at least one dose is given, that is ensured. That is the reason why I give full dose initially only before catheterization. Now this is catheterization. Again, that bromage grip. Yes, only 2 to 3 centimeters of catheter is kept inside, not longer than that. And then catheter is withdrawn to the required markings. Now this particular patient, he sat on the table, but because of excessive flexion of the head, he got vasovagal. So I just laid him down horizontally on the table, and then cervical epidural was given in a lateral position. Technique again remains the same, but I find sitting position is better than lateral. Now see, I have hit that lamina at that moment. Then I have withdrew the needle till subcutaneous tissue, then again redirected it. Little bit cephalad, angulating. Yeah, angulating. I am puncturing cephalad. Then again, airfield syringe is attached. Again, bit by bit, I am going to the epidural space. See, that is the epidural space. Again, see my plunger. Look at the plunger. I am not pushing air. I'm just getting that tactile sensation of that. Then this needle is rotated again to the capillary direction. This is a test dose. And then on the right side is a full dose is given. That's it. Now I will take the catheter and look at the stimulus patient gets while threading this catheter. He just jerks off. Just have a look, closer look. Yeah, at that point. That the reason being you hit the dura or some nerve root there. That is a consistent sign of you are in the epidural space. Then again needle is withdrawn over the catheter and again pulled back to the required length. These are the drugs and doses. Usually I give 3 ml of lignocaine with adrenaline and loading dose of 7 ml of bupropion 0.5%. And adjuvants I use fentanyl, clonidine, buprenorphine. All these improve the quality of the block and clonidine and buprenorphine extend the duration of block. And these doses depend on the size of the patient or height of the patient. You can reduce these doses in a smaller patient with less height. And approximately calculation, that is a formula, calculation of per segment drug doses, 1.2 to 1.5 ml per segment. So for an average height patient, you require 10 to 12 ml of local anesthetic. Now, this cervical epidural has certain effects on the circulatory system. And just a second. The serious effects observed during this cervical epidural are complex and variable. And depending on multiple factors like extent of sympathetic denervation and spared autonomic activity, a blockade of T1 to T5. Now, T1 to T5, these are cardio accelerator or cardio inhibitory fibers. If these are blocked, then it becomes a little bit of variable effect, cardiac effects. The pharmacologic effects of local anesthetics and adrenaline use, test dose adrenaline use, and patient's cardiac conditions. So net result is decrease in heart rate, ejection fraction, cardiac index, mean arterial pressure may remain unchanged or decrease. Ventricular afterload and myocardial ischemia is decreased. Now, these resultant decline in all those parameters are beneficial to patient, but one needs to be careful in low cardiac output states like severe aortic stenosis or mitral stenosis or hypertrophic obstructive cardiomyopathies. However, these bradycardia and hypotension are clinically responsive to chronotropic or inotropic drugs. Respiratory effects results from the blockade of cervical segments from C3 to C5 and which gives rise to the phrenic nerve. And also as a result of blockade of intercostal nerves. And the phrenic nerve blockade is not complete for that matter, but around 60 to 70% of block is seen, sparing around 30 to 40% of phrenic nerve activity still intact. And it depends on the concentration of local anesthetic. So net result is decrease in almost all respiratory parameters like tidal volume, functional residual capacity, forced vital capacity, FEV1, and vital capacity. Although SpO2 may be unchanged, but PCO2 is with increase in respiratory rate. And these parameters, they become clinically significant in patients with pre-existing restrictive respiratory pathology Hence, patients with severe restrictive diseases, they are contraindicated. Although bronchoplastic anemia, asthma patients are benefited with this block. There is much curiosity about this phrenic nerve. Everybody asks why phrenic nerve is spared. I am still in dark. I don't know why phrenic nerve is spared, but there are certain hypotheses which says the spread of local anesthetic is maximal in dorsolateral epidural space, which carries sensory roots, and it is minimal in anterior epidural space, which carries motor roots. So this is one of the hypotheses. Another thing is concentration of bupivacaine is very important. Concentration of bupivacaine or ropivacaine or any drug, that is very important. And for bupivacaine, it should never exceed 0.5%. And then physicochemical properties of bupivacaine, ropivacaine, we know disparate. There is a disparity between sensory and motor blockade of bupivacaine and ropivacaine because it is far greater with bupivacaine and less with ropivacaine again. And probably this might be the reason why phrenic nerve is spared in cervical epidural. These are contraindications, routine contraindications again. And recently there is a resurgence of imaging guidance techniques like fluoroscopy, ultrasound for real-time location of tip of the epidural needle. And another is endoscopic optical coherence tomography. It is based on real-time forward imaging of the tissue in front of the needle tip. But all said and done, even with those guidance system, I think lot technique remains the safest. And once you get that expertise, it is a wonderful technique. So friends, I will not be out of place if I mention my experiences about cervical epidural anesthesia at annual Bhamragad surgical camp. And it is organized by Rotary Club of Nagpur every year in the month of January. And this Bhamragad Hemalkasa is a picturesque remote area, very beautiful area, almost 350 kilometers from Nagpur. Road is wonderful. And it is situated at the confluence of magnificent three rivers. And it is surrounded by dense jungles of Bhamragad, Allapalli range. And it is inhabited by our poor tribals as also Naxalites. And this Lok Biradari Prakalpa run by Honorable Padma Shri Dr. Prakash Bhavamte and family is rendering health, educational and other services and doing a Herculean job of uplifting lives of these poor tribals since the last 50 years. And incidentally, they are celebrating 50 years of their inception. This December, I might go for that function. That is Golden Jubilee celebration of Lok Biradari Prakalpa. And since last 22 years, I am offering my services as an anesthetist to Hemalkasa Surgical Camp. And every year, scores of surgeons and dozens of anesthesiologists, we go there, offer our skills to these poor tribals. And earlier, now facilities are better, but when we used to go earlier, with limited resources and number of operation theaters, surgeries under GA we could do was very limited number. And large number of these tribals were turned down and sent back. And that was a very traumatic experience for all of us, not only tribals, but we also felt very bad because they are going back. And because poor tribals, they waited for this camp throughout the year. And now another wait for a year meant a lot to them. At this point, I've thought over and introduced cervical epidural for thyroid, breast, and shoulder and surface chest surgeries, with the result that number of surgeries drastically increased, and we could do almost all surgeries within the camp days, and relieving these poor people from the unimaginable sufferings. Hence, utility of this block is immense in mofussil areas, I tell you, provided some expertise around to tackle with the unforeseen event. Last year, Dr. Maya was there. We had a refined time over there, and possibly I hope this year also she comes there. And anybody, if anybody want to share those experiences and want to come and share his skills there, just call me. Next month, on the date of 18th, 19th, we have camp over there. So now these three ladies are sitting for their turn for epidural epidural catheter insertions. And these three ladies, they have already this epidural catheter is inserted and they're waiting for their turn to come. So that's how we reduce the actual surgical time, and the number of surgeries went up drastically. So friends, to conclude, this technique is safe and effective for thyroid surgeries, and it offers benefits to cardiorespiratory compromised patients and avoid general anesthesia and minimal consequences. Although negligible complication rate, all safety guidelines are to be followed, and GA with all associated risk is eliminated. And again, it allows intraoperative voice monitoring for thyroid surgeries. Phrenic block is there, but again, this concentration determines the blockade of phrenic nerve. And careful patient selection and reassurations, you can safely give these blocks. And it is, although it is a skill technique, high degree of technical proficiency is required. But you can try it and get proficient in these techniques. And then again, imaging and guidance takes have a non-safety and success rates of this epidural block. Thank you.
Thank you, Dr. Rajurkar, for your proficiency and expertization in this field of cervical epidural anesthesia. It is really wonderful to see your blocks and the techniques which you have described, either in the sitting or maybe in the lateral. So
Yeah.
I really thank you for your mastery in the epidural block, because it is a boon for them. And those who are benefited, really lucky with your hands. Thank you.
Thank you. Thank you, ma'am.
Can Dr. Markandet introduce, start. Dr. Vivek Mehta, you may start your presentation now.
Yes, ma'am. Need to share my screen. Ganesh, please.
Dr. Rajurkar, stop sharing your mobile.
Yeah.
Meanwhile, Dr. Vivek is sharing his screen. I would say Rajurkar sir had done wonderful cervical epidural for thyroid surgery. In last year, we had done 3-4 cases under cervical epidural thyroid cases, and they were very cooperative also. So that makes a difference, I think, sir. If patient are cooperative and your proficiency, both things go hand in hand, and we had done wonderful cases that time. And sir used to give epidural, used to insert the epidural in the recovery room. And then we used to take the patient operation theater.
It's a great learning, great learning routine. We go almost dozen of anesthetists go there, and then they learn
Yes,
about
sir.
this cervical those settings. It's a wonderful place. Yeah.
It was like for us, it was like a get together, and lot of cases we did, and so many right from the neonate to older patients. We had done lot of cases in those 4 days, 3-4 days. Thank you, sir. Thank you so much.
Thanks, ma'am. Thanks.
Ganesh, please, can you share my screen?
Visible.
Yeah, thank you. Thank you. Next slide, please. Next slide. Yeah. So, am I audible, ma'am?
Yes, yes.
Yeah. So, the majority of the parts, sir, has been covered actually. Actually here we were talking about the nerve supply of the anterior part of the neck, which is mainly is from the majority of the supply of the anterior part of the neck is from ventral ram of C2, C3, C4, from where those nerves come and they form a cervical plexus up in the neck. And actually they come out from the deep part of the neck, piercing the prevertebral fascia, and then superficial part of the neck. They again pierce the traversing the superficial part of the cervical fascia, and then supply the subcutaneous part of the neck. It supplies. It has. I mean, it gives four nerves, which is. I mean, like there are four nerves. One is lesser occipital, greater auricular, and the transverse cervical, and the supraclavicular nerves. So these four nerves supply the anterior and the lateral part, and anterolateral and the medial part of the neck up to the clavicle. And here in this part, we can do this the surgical procedures like the thyroid surgeries, parathyroid nodules, and even we can do the cervical, I mean, central line insertion. I mean, even the clavicle surgery we can do, but there's a it should be in adjunct to the interscalene nerve block, because the cervical plexus is covered with, it is formed from the C2, C3, C4, but the clavicle lateral part of the clavicle is supplied by the C5, C6. So that part is supplied from the interscalene nerves, in the plexus, brachial plexus. So in that case, it should be, in addition to that, we need to give interscalene nerve block also here. Next slide, please. Ganesh, next slide, please. Yeah. So as I told you already, the anatomy, the four nerves. So we'll look at the diagram. Next slide, please. Next slide.
Yes. Retro show है.
Yeah. One thing here actually, in the majority of the supply of from the deep the cervical plexus block is sensory supply. Only few muscles, I mean, few part of it is supplied to the motor, I mean, the muscles. So that motor supply comes from the deep cervical plexus. So that deep cervical plexus motor supply is mainly to the strap muscles. And in that case, actually, if we the superficial part of the cervical plexus and the deep cervical plexus block, the difference is only about the motor supply of the nerves. So here, the nerves, you can see the I mean, the upper side there are two nerves. In front of the auricle, it is a greater auricular nerve. On the occiput, it is lesser occipital nerve, and anteriorly it goes the transverse cervical nerve, and inferiorly to the clavicle it is supraclavicular nerve. This is the distribution of the area which is supplied with the cervical plexus. Next slide, please. So, looking at the technique of nerve block, I mean, this cervical plexus block, usually there are two techniques. One is the landmark technique, and other is the assisted USG guided technique. So landmark technique is there are two parts actually. One is the superficial cervical plexus block, and the other is deep cervical plexus block. Giving superficial cervical plexus block is very easy, and because of its presence in the superficial area. So the nerves which are coming, supplying the nerve, the neck area, these nerves are originating from the backside of the sternocleidomastoid muscle. So the landmark would be the sternocleidomastoid length we should calculate, and the midpoint of that. The length, how do you calculate it? From the mastoid process up to the clavicle, where it is originates and where it insert. So in this, the center point of that is the landmark where we should insert our needle. And below the sternocleidomastoid posteriorly, there is the fascia, cervical fascia. In that layer, all these nerves are lying. So, targeting all the nerves superiorly, inferiorly, and medially, we should give injection on each side. Like uh, uh, with the 23 gauge needle, we'll insert the drug and directing initially towards the inferior side and giving the local anesthesia there. The drug and volume can be discussed. I mean, even I will tell you, but the madam will explain you. The Manisha madam will explain you everything about that. And in medially also to the transverse cervical nerve, we should give local anesthesia there, and the directing superiorly also. The depth should be around 1 to 2 centimeters. That should be enough because it's a quite superficial layer. Next slide, please. So, deep cervical plexus block. This is something tricky. I mean, it is associated with the complications. That is why this deep cervical plexus block nowadays it is not used because of its complexity and because of the complications related to the block. So because we are very near to the nerves, vertebral artery, and all the vasculature. So the absorption rate and even the absorption into the epidural spaces can lead to complications. So anyway, but looking at the target points is here you need to locate the transverse process of C2, C3, and C4, and hitting that transverse process with the needle and give local anesthesia there. At each level, you can give 1 to 2 ml of local anesthesia. Ideally, this is if you can give at single point also, that is sufficient because it's a quite small space that gets spread into the adjacent area, so the effect will come. And anyway, the nerves which are getting blocked here are also getting blocked in the superficial area. So you need not to give block here. Only if you want muscle relaxation of the strap muscles, then only this is necessary. For this reason, we have in our study in 2013, we did deep cervical plexus block also on one side. Here, there is one thing I forgot to mention you about phrenic nerve. Usually, the phrenic nerve is very near to this deep cervical plexus block because it into the prevertebral fascia, below the prevertebral fascia there is a phrenic nerve. So if you inject the local anesthesia beneath the prevertebral fascia, there are almost more than 60 to 70% chances that it will get anesthetized. I mean, there are chances of diaphragmatic paralysis, those temporary, but there are chances. So in that case, here you can give the deep cervical plexus block, but you should not give on bilateral side. Superficial cervical plexus block you can give on the bilateral side, but not in deep cervical plexus block. Okay. Next slide, please. So the other technique is USG guided. It seems quite complicated, but it is very easy. I mean, this is the one of the most easiest nerve block which can be given with the USG guidance. So here, usually, the most superficial part is the strap muscle. Below that, on the left side, this is the beak appearance is the sternocleidomastoid muscle.
Can
And
you show pointer, please? Can you show by the like arrow?
Yeah. Actually, this is not my screen sharing, so I cannot show it.
Okay.
It's the left side of the screen, upper left side of the screen, showing the beak-shaped muscle. That is the sternocleidomastoid. Below that, there's a fascia. The inclined part is the shape. It in the plane in which the nerve plexus resides. So that is the area where we need to give local anesthesia. There's one more slide I'll show you. Next slide, please, which has very good resolution. This one. Here, the pro position should be horizontal, and I mean, you can the medial part should be on the medial part. The marker should be on the medial part of the patient, and the superficial. This is SCM, means sternocleidomastoid muscle. Below that, there's a fascia here. That fascia is the cervical fascia. So in that fascia, you will get the superficial cervical plexus nerve plexuses. So by giving local anesthesia in that plane will lead to anesthesia of the neck region. And the volume here you can give under Yoichi guidance. It is hardly of 5 to 8 ml is sufficient. If you are giving blind block, that it should be it is blind means landmark technique. It can be around 8 to 10 ml is sufficient on each side. On the if you are performing on the left side, it 10 ml on the left side, right 10 ml on the right side. So next slide, please. So before that, the dose of the I mean the volume I had told you, the dose should be, it is as per the patient, the 2 milligram per kg of the I mean lignocaine, 5 mg per kg of the lignocaine, and 2 mg per kg of the bupivacaine. But here we need not to give full dose because the volume requirement is quite low. I mean, you need not to give 30 to 40 ml because 10 ml in the superficial plexus on each side, 10, 10, 20, and for 2 to 3 ml in the deep cervical plexus. Hardly of 20 to 25 ml is sufficient. So you need not to give total amount here. And in some cases, we may need to give skin site local infiltration. And
hold on for some time. Just wait. Ganesh, can you mute all the participants except the host? There is a lot of noise.
Yes, ma'am.
Yeah. So the looking at the complication rate is too high in deep cervical plexus block, but in the superficial, it's quite safe and easy no block. So in that case, majority of the neck surgeries which are superficial can be done under superficial cervical plexus block itself. Deep cervical plexus block is actually, it is if we avoid, that is good because the complications related to are high, like the intravascular absorption of the local anesthesia and the epidural absorption of the local anesthesia. Phrenic nerve palsy is common while we give deep cervical plexus block, and inadequate action is one of the, I mean, complication because it may lead to pain and vasovagal attacks. Because we faced one such case, so I stated that. Next slide, please. So, what's the take-home message? It is, if we are doing the superficial cervical plexus block, then it is quite easy and quite safe. but you should be trained enough to do that before directly jumping to that. And deep cervical plexus block, nowadays no one does it. Very rarely people do it. But even if you're trying, be cautious and do it under someone's guidance who has done those kind of cases. And uh, this is the reason being I told you. I mean, the complications which are attached to it. And this is definitely the surgeries which we can do under these superficial and deep cervical plexus block, which leads to a very economic alternative for the general anesthesia. But even though if we are doing it under regional anesthesia, we need to be ready with the general anesthesia standby, because this anytime if patient may have pain or any kind of complication, you need to be ready with all the equipments for general anesthesia. And this is very good, really. This kind of patient which we had seen, which we did 35 cases around. So all the patients who have undergone the surgeries, thyroid surgeries under these block, had very good pain relief even post-operatively and intraoperatively. And next slide, please. These are my references. Thank you. Next slide, please. Next slide. Thank you.
Okay, Dr. Vivek Mehta, Vivek Deshmukh, sorry. You presented quite well in spite of all hurdles. We really loved your superficial as well as deep. We may try and avoid deep, but ultrasound, I think, definitely helps better than landmark guided, because it is a precise thing and we can restrict the volume and we can restrict the complications, I suppose.
Yes.
Dr. Markande, unmute yourself.
Hello, am I audible? Now our
Yes,
next
madam,
speaker is Dr. Manisha Sapate. She is Assistant Professor, Department of Anesthesiology, PG Institute at YCMH. And she is having 12 years of teaching experience in Dr. D.Y. Patil Medical College and PGI Pimpri. There are total 8 publications, 4 international and 4 national, and 2 book chapters to her credit. And she is also co-editor of SAPC book. So over to Dr. Manish.
May I audible, everyone?
Yes.
Ganesh, please share the screen.
Thank you, madam.
Ganesh, please share the screen.
Just a moment. Now it's visible, madam.
Yes. May I audible to everyone?
Yes.
Yes, Manisha, go ahead.
Yes, thank you, ma'am. Thank you, Markande, ma'am. Actually, my teacher introduced myself is very proud moment for me. So I will start my presentation. The series of cases of thyroid nodal surgeries under cervical plexus block, a safe and effective alternative to general anesthesia. Next, please. Next slide, please.
Can I show you the slideshow mode so that we can see the full screen slide?
Yes, Ganesh. Actually, Ganesh is
Yes, madam. Yes.
yeah.
Yes.
Yes, I like operating under local anesthesia because the patient would be safe, the distress is negligible, the recurrent laryngeal nerve may be guarded, post-operative vomiting does not occur, pint of fluids may be given by the mouth, and from the moment of the operation is over, the patient is happy enough to smile and free from unpleasant sequel of the general anesthesia. This quote is by the T.P. Dunhill in 1912. So this quote will be my starting point of this presentation. Next slide, please. Next slide. Thyroid surgery is performed by the large number of Yes. May I audible to you? Yeah. Yes. Yeah. As you know that thyroid surgery is performed by the large number of surgeons and having the various expert experience in the thyroidectomy. The standard technique involves the use of general anesthesia, which provide patient a comfort, but practically it is unlimited time and may be required a more time for the complete recovery from its effect. So historically, thyroid surgery was conducted under local anesthesia by the surgeon, but they have required significant expertise in the treatment of thyroid disease. Over the decade, there has been a renewed interest in the art of performing the thyroidectomy under the regional anesthesia or local infiltration. So these are the old is coming in the new form. So we have to accept the things and go with this new technique. Next, please. So regional anesthesia is now being accepted universally as a safe alternative to general anesthesia for thyroid surgeries. Thyroid nodule surgeries were carried out to find out the outcome of these surgeries. So my aim is to analyze the effectiveness, safety, and patient acceptability of performing the thyroid surgery under regional anesthesia. We have objective to provide. Previous slide, please. Previous slide, please. Previous, please. Yeah. So my aim is to analyze the effectiveness, safety, and patient acceptability of performing thyroid surgery under regional anesthesia. Objective of our cases to provide the anesthesia and analgesia in such a way that the patient get the post-operative good outcome and to ensure the smooth post-operative recovery. Next slide, please. Next. So material and method in which after approval from the hospital ethical committee, we enroll the 30 cases over a period of 12 months at the YCM hospital, Pimpri Chinchwad. The cases were scheduled for Ganesh, please slide.
Ganesh, what's happening at your side?
Ganesh, after next slide only you can change the slide, please.
Yes, ma'am. Network issue from my side.
Next. Next. Ganesh, next slide, please. Next. Yes. The thyroidectomy surgery for the thyroid nodule was performed at our hospital as a YCM hospital, Pimpri, Pune. Next. After approval from the hospital ethical committee, we enrolled the 30 cases at the period of 12 months in YCM hospital. The cases were scheduled for the thyroid surgery having the diagnosis of thyroid nodule only, and the size is less than 5 centimeter. After taking the informed consent obtained from the all patient, we were willing to undergo the thyroid surgery, awake under regional anesthesia. So consent is very important for these cases. We include the inclusion criteria. We have to include the age group of 20 to 50 years, patient having ASA 1 and 2 grading, and the weight about 50 to 70 kg. With exclusion criteria, patient having, Ganesh, please. Ganesh?
I think he's telling he is having problem at his side in sharing the.
Yeah, I think so.
So you can share on mobile. Is it possible?
So I can share the PowerPoint. What I can do?
हे मोबाईल वरती जॉईन कर आणि ते जसं राजूरकर सरांनी केलं तसं करता येईल. स्लाइड्स पहिले पीपीटी ओपन करून मग झूम ओपन करून तिथे स्लाइड्स.
ओके. एक मिनिट. Sorry everyone, actually some technical issue, it is very disturbing the everything. काय करायचं? नाही पण नाही ना, ते मला दाखवा. भावेश, काय करायचं मी?
मोबाईल वरून आपलं लिंक ओपन करायचं, म्हणजे त्याच्या अगोदर ऑलरेडी प्रेझेंटेशन ओपन करून ठेव पीपीटी मोबाईल वरती.
मोबाईल वरती
पीपीटी ओपन करून ठेवायचं.
Just wait, I will ask my daughter to do the things. आता मी मोबाईल वरती ओपन केलं. आता
आता झूम वर जाऊन तिथे शेअर स्क्रीन करायचं.
मोबाईल मध्ये झूम ऑन करायचं. मोबाईल थ्रू यू नीड टू लॉग इन. मोबाईल मधलं झूम ऑन करा.
आलं.
आता दिसतंय. एम्स एम पर्यंत. बस. Can everyone see these slides?
Yes, aims and objective.
Yes.
So I will let me go. हे करू का?
Slide show resume कर. Slide show.
Okay.
ठीक आहे, असंही वाचलं तरी.
Okay, yeah.
Like that also you can go ahead.
पुढे फॉरवर्ड केलं. So to next slide. So, okay, everyone able to see the slides, please?
Down.
Yes.
To move down.
Okay. Exclusion criteria includes the refusal of the patient having the allergic to local anesthetic, the patient having the excessive anxious and the anxiety, the patient with the deafness and the sleep apnea syndrome, with the history of recurrent laryngeal nerve palsy and the site of local sepsis in the area of block, and also the history of retrosternal goiter. And one more thing I have to add, the patient having the bilateral nodule with the more than 5 centimeter size, we do not include it in our study.
Manish, you have to go to that exclusion slide. Your slide is showing aim and objective.
Okay, ma'am. Ma'am, are you able to see aim and objective now? Slide?
Yes.
Okay. Next, design
No.
Huh?
No.
No.
Yes, ma'am?
No.
No,
No.
no.
अच्छा ते नाही बघू शकत आहे. Madam, you are not able to see the design slide. Next slide.
No.
No.
Okay.
No, you can log in from your mobile, madam.
Actually, I don't know how to log in. Sorry, friends. Actually, I am not able to log in on mobile.
प्लीज एकदा स्टॉप करा स्क्रीन शेअरिंग.
हा, गणेश
Okay.
करतील एखादं.
Yes. थांब ते गणेश
2 मिनिटं मॅडम.
अरे ते थांब नको करू शेअर स्टॉप.
Now we can see setting and design. परत घे.
नको करू.
Yes.
तर आता
Yes, sir.
visible.
Okay, sir.
Yes, sir. Next slide now.
Yeah. Next slide, please, Ganesh.
Yes.
Yeah. So, in our cases, we use the drug injection lignocaine. Plain lignocaine we use 5 milligram per kg, and injection bupivacaine 0.5% 2 milligram per kg. So, for the superficial cervical plexus block, we give the 10 ml volume on each side. And for the deep cervical plexus block, only the 3 to 4 ml at the C4, as the Dr. Vivek told that we have given only at that level where the transverse process we give the unilaterally. So before doing the after the drug, all the patient we pre-medicated with the tablet alprazolam 0.5 milligram one night prior to surgery, and in operation theater we secured IV line and ECG, NIBP and SpO2 monitors are attached to the patient. Pre-medication as an antiemetic injection ondansetron is given 0.1 milligram per kg, and bilateral superficial cervical plexus block were given, and unilateral deep cervical plexus block is given. So, and if we required the incision site, we give the 4 ml infiltration depending on assessment of the block. After that, only we give the incision site block. The onset of the action for this block is 10 to 15 minutes. So, first sign of the nerve block is decreased sensation in the area of distribution with the respective component of the cervical plexus. After giving the block, all the patients were explained about the neck extension position for the ease of surgery at the request of surgeon. And during operation, we give the oxygen by the simple face mask. And after 10 minutes, we give the injection midazolam 1 milligram means 0.2 milligram per kg. Injection pentazocine means 14 0.3 milligram per kg. Previous slide, please. And again, the dexmedetomidine as a component, as a adjuvant, as a point.
When it goes to previous, there is a problem, I said.
Yeah, next slide, please. Next slide, please. Sorry. Sorry, friends. Ganesh, next.
You need to share first.
पहिल्याला केला मी.
Yes. Injection dexmedetomidine 1 mic per kg bolus and maintenance about 0.5 mic per kg per hour by the syringe pump. Injection paracetamol 1 gram IV given intraoperatively. This multimodal analgesia is required because of patient is anxious and we are giving the regional anesthesia. So for every cases, always the multimodal is the good choice to give along with the regional anesthesia. Next. Intraoperatively, patient were positioned. The draping was applied in such a way that so as to leave the portion above the chin free to facilitate the intubation if required. Because we don't know patient is anxious. This is a new thing to them. So in emergency or any handling or something happened, always the plan B, like general anesthesia is always there. So intubation is more important. So we have to keep this in the mind. We have to keep the chin free. So doses of sedation were adjusted according to the weight of patient, ensuring that the patient were able to maintain the airway independently. This is also very important because when we give the depending on that, actually we selected the patient 50 to 70 weight only. So that much is not the problem from our side. But always obese patient with a small sedation, always there is a problem not maintaining the airway. So that is very important. Vitals were monitored.
Go on to discussion.
Okay, discussion slide. Discussion. We are doing the thyroid surgery is in a such a way that there is always the complications are there, but it is very difficult to assess that complications. So always in the mind we have to know about the complications of that. So advantage of the regional anesthesia, it is like it is not that much easy. The expertise are required, but the landmark are so easy, so we can do it very well. 1-2 cases is very important to do under the guidance of senior person, and after that we can do it routinely. So in our institute we did it first 2-3 cases with the superficial block and give the GA, and after that with the plain regional anesthesia we plan in such a way that we can do easily. Actually, in regional anesthesia or any new things we have to add in the cases, in the surgeries, the teamwork is very important. From our institute, Dr. Markandi madam, Dr. Gore sir, Dr. Andurkar madam, myself, and the Vivek sir, both all are will discussing the things. Okay, we can do this because the first now this like now the everything is available on videos, but when we tried at that time 2013-14, that time only the literature and the research is there. We just find out that literature and we did that surgery successfully. Actually the confidence is we got the confidence with the help of our senior faculty like Markande madam and all these things. They told that me and Vivek sir to do, we are here only, so we did all the cases successfully. The advantages are they are safe, we can do it very easy approach, but sometimes advantage having the disadvantage also. So if we go that intravascular is, if it is gone to the intravascular, the complications are more, and we can having the approach in such a way that we can handle this thing very easily. So I can conclude my topic with this, that cervical plexus block is suitable for the thyroidectomy. The technique is simple, safe, effective, cheap when compared to the general anesthesia. And the acceptability, actually when the first time the ENT surgeon, general surgeon, they are not accept, we are doing the regional anesthesia for that. So that actually the confidence with the surgeon and the convince, like we have to very much counseling part with the relatives is very important with the at the also the patient also. The counseling is also very important for doing the such cases. So the overall quality of the operating condition is assessed by the surgeon was very satisfactory. So careful patient selection is one of the important criteria. Actually big thyroid, the anatomical landmark is not there. Now the USG is available, but when we done these cases, that time the landmark technique is there. So the anatomically, we tried only on the thyroid nodal surgeries, which is having the size of less than 5 centimeters. So the role of adequate sedation is very important to relieve the fear and anxiety and discomfort of the patient. So I conclude that the cervical plexus block with adequate sedation to effective method and for the thyroid surgery and can be considered as an alternative to the general anesthesia with the conventional general anesthesia. So the expertise and the practice, that is very important for doing such cases. Thank you. Thanks a lot, ma'am. My references are there. Are too many literatures are there and references also there. But these are the actually from 2000 only they are doing the surgeries. The references are like general anesthesia with the post-op analgesia. One more thing I have to add, that the rescue analgesia after the regional, that superficial and deep cervical plexus block, it is like rescue analgesia is very less, because the comparative study are there. General anesthesia we have to require early rescue analgesia as a tramadol, but for the regional with the superficial cervical plexus block, the rescue block is delayed. Actually double the time is required for the rescue analgesia. So these are the things I have to explain with my slides. Sorry friends, actually it is disturbance from the technical point of view. Thank you, thanks a lot. Thank you, sir.
Thank you,
Thank you,
Manisha.
Manisha, for your confidence and the way you spoke and very confidently. And I suppose only under sole anesthesia. Is
Yes.
it under the sole anesthesia you did, or with along with the support of general anesthesia?
No, it's a sole anesthesia, ma'am. We had done all the cases, actually more than 30 we have done, but for the enroll the cases they are 30. And during the surgery there is hemodynamic stability is like it's awesome. We can manage it very well. So the same thing with the top. Markanda madam has know that first case we done the top that time also. The confidence after doing the cases repeatedly we get the confidence and we can do it very easily. So that is very expertise will be become after that only. Yes, ma'am.
Okay, thank you very much. One question from my side. I mean, all of you have presented very well, but my question is how the patient bear the position. That is always a shoulder extension we need for such surgery. Do they bear for the longer time?
That's that's the part actually, ma'am. Here, usually, majority of the surgeries they are done are small thyroids, and usually they need superficial cervical plexus block. But we have added deep cervical plexus on the side where the thyroid nodule was there. So that gave the comfortable position for the patient because the strap muscles get relaxed with the motor involvement. So, and in addition to that, definitely that's not the only part. In addition to that, we have given the mild sedation to the patient that lead to, comfortable position to the patient.
What if you do have an inadequate block? Like if you have an inadequate block, so what is your plan B in that case?
Yeah, we have encountered in that for the
Out of 30 cases, the 2 cases we have to convert it into GA. That time, same thing I told in that my slide, we have to keep the ready. That drape should be in a such a way that at any time we can intubate the patient. So that we can do with all these things.
Okay. Madam, Markandeya madam, can you read question answers? Should we take question answer session?
Yes. Yes. No questions.
Any questions?
Hello.
Yeah, ma'am, it is there in the chat box.
Just see in the chat box.
There's a question I can read. Would you consider, LA given at incision site in all cases? Not actually. Whenever we felt there's an inadequate action in the superficial area, there only we give local anesthesia. Maybe it's around in 30 cases, it is more than actually 35, 40 cases now. In those 40 cases, we gave around maybe 5 to 6 cases, we had to give local anesthesia at the incision site.
Then somebody asked if you can you consider a supraglottic device instead of EDT in your plan B? Okay. In your plan B, can you consider supraglottic airway device instead of ETT, endotracheal tube?
Here, actually, it's a kind of inadequate analgesia, inadequate anesthesia. So in that case, the plan B should be robust and it should be, have a 100% to the, patient. There should not be any light anesthesia. So general anesthesia with endotracheal tube should be, we felt that is quite safe and good way. So in that case, we
during handling the LMA might slip, isn't it?
Yeah, because during surgery,
LMS were not available that time.
yeah, even that was the case actually. LMS were not
They were
available
not
in those
available
days.
easily at that.
If at all LMAs are there during the handling of trachea, they
Yes,
might
yes.
They
Even
might
it would have been available, but we would not have used that because of this problem.
Problems. Yeah, one thing I have to share, one thing, ma'am, can I tell it? Ma'am, actually, the surgeon first 2 times, they are very reluctant to do the surgery because convince with them is very difficult. After that, we have to told that the handling of the nodule is also very important because patient is not totally under the deep anesthesia. So handling of the tissue and dissection is very important, but they are satisfied because the bleeding is less. So they are happy, and the next time they tell, oh, you can give the superficial and deep cervical, so we can do the cases. So after that only we are routinely doing the superficial, and our resident also were happy that time we can do these cases with the superficial and deep cervical plexus block.
The surgeons are always reluctant initially.
Yes,
and
ma'am. Yes, ma'am.
They see the advantages and patient's comfort. Then they
Yes.
realize the value of it. Okay. Another question: have you used additives in your blocks? You said lignocaine and bupivacaine. Had you?
No, we didn't add anything, ma'am. Just only the multimodal analgesia, dexmedetomidine, pentazocine, and midazolam. That's
No additives in the block.
Not in the block.
No block, no nothing.
Nothing was added in the, regional anesthesia, apart from lignocaine and bupivacaine.
The sir is asking, can we do lap thyroid surgeries under block? 3 approaches: transternal, submental, and retroauricular.
Thyroid surgeries definitely we can do, but if it is, retroauricular, it is a little bit difficult. But the retrosternal also it is difficult.
Actually, transaxillary, the approach is different because in our now the people are doing that transaxillary approach towards the, so we are giving the GA. We didn't try it also because it is very difficult to manage all the things.
In this case, the cervical epidural would be the option.
Sir's technique is better than our technique.
Paliwal, you can unmute yourself and you can ask, sir. No problem. Dr. Paliwal, sir.
मार्कंडे मैडम ने काही बोला?
Hello.
Yes, Dr. Paliwal.
Nowadays, they use skeletal muscle relaxants orally, like tizanidine, because they relax the spasm and muscle spasms. So the dose is 2 to 4 milligrams, but it is central alpha-2 adrenergic agonist. So it's structurally related to clonidine, but there is no hypotensive effect. So back pain and muscle spasms and muscle pain is less. So this one also you can add.
Okay.
Oral tablets.
पालीवाल सरांना काहीतरी बोलायचं आहे. डॉक्टर पालीवाल.
Hello. Madam.
Yes.
Good evening, everyone.
Good
Actually,
evening.
I have done a lot of cases under epidural and also under these blocks. But what you need is a cooperative patient, also a cooperative surgeon.
Yeah.
Because what happens when the surgeon, they start mopping with vigorously, the patient starts getting discomfort.
Yes.
So we had to convert one such patient into general anesthesia when surgeon suddenly pressed very roughly over the operating area. So what you need is a cooperative patient, cooperative surgeon, and sedation in the form of Dexcat, what we use routinely, that does not hamper your airway in any way. And the other technique is it can very well be done under segmental spinal also. These laparoscopic surgeries, but we usually don't recommend because people should not start doing it unnecessarily because the blocks are very good, superficial and deep cervical plexus blocks.
Sir, what level? I mean, segmental spine or thyroid?
Similar to your segmental epidurals, it works similar to. What we need to do is use hypobaric drugs. You can use hypobaric drugs at mid-thoracic or upper thoracic levels, very low concentration, low volume, so that the block which is produced is mostly sensory. Just like your segmental epidurals, it does not involve these your phrenic nerves, and patient should not have any discomfort.
In the volume per segment, sir?
The only thing is the duration is very limited, around 60 to 70 minutes.
Okay.
The advantage epidural has, you can top up the dose, but
Dose.
in segmental spinal, you don't have that advantage. So you can combine it with some blocks.
Okay. Okay, sir. Thank you, sir.
Thank you.
My question to Dr. Rajurkar, one should not dream of it, but what happens like if a dreaded complication like a dura puncture while giving cervical epidural? One should not dream of it, but if it happens, what will be a further management? Is Dr. Rajurkar there?
Yes. Yeah, it's a complication. Definitely, it's a complication. But I will tell you what Bromage has said. You should do at least 50 thoracic epidural before you try your hand on cervical. And I would say not 50. You should have 100 patients. But once you get that expertise, I tell you, it's easier to puncture dura at lumbar level than cervical. Really, I didn't come across any dural puncture at cervical level. But if at all it happens, then you have to take the regular measures. What measures we do? You have to identify it's a dural puncture now without any cord injury.
Yes.
So it is a possibility, no doubt. But then what Bromage has said 50 years or said 60 years ago that you should have done 50 lumbar epidurals or thoracic epidurals before you.
Always a fear while like injuring spinal cord.
Yes, yes. So adequate expertise should be there. No ISS should try the cervical epidural for these surgeries. And but once you get that expertise, I tell you, it is as simple as lumbar epidural. Once you get that expertise, it's so simple.
You always give in the on the operation table, or you said you stopped giving on the
Operation table. I'm in a private this thing. I got my hospital, and directly patient is taken inside the operation theater. We just finish our job 10-15 minutes. It doesn't take too long.
Patient is sitting on the OT table. Okay.
Patient is sitting on the OT table.
I have a question for you, sir.
Yeah.
Do you give entry on the ipsilateral side or on the from the center for cervical epidural?
From the midline approach. Midline approach.
Okay. Usually, I mean, there are chances in 10 to 15%, but midline the fascia may be lacking in the 10-15% of the cases.
Yeah, I have shown that slide. This lamina is sparse in some cases at that level in midline area. But once you get that expertise, no, you don't need that feel of puncturing lamina.
Okay.
You have to get that feel and you have to learn that feel. You are inside this space. I can certainly tell you, I am in the cervical epidural space without, in fact, testing for this. So it's a matter of practice. It's a matter of practice.
Yes. We in pain management usually give cervical epidurals from the, paramedian's approach, because it gives very good feel. The puncturing that fascia is very good feel. From the center, from the central part, there are sometimes we may not feel.
Yeah, 8 to 10% of patient has got that. It's 21 hours. That interlaminar, this ligament is not fused in the midline. Then you tend to pierce that ligament without any obstruction or feeling that piercing, that the tactile sensation is not there.
Yes.
Yes.
Sir, can I ask one question, sir?
Yeah.
Sir, you told that you have to give the on the table, but actually we given the MRM cases cervical epidural, but it is very difficult to like our stability the patient is on and we have two on the steps. So how we can manage the things, because so we two cases we did it.
I again started my practice on a cervical epidural with a patient sitting on stool.
Yes.
And with his head resting on the operation table.
Yeah. Yes.
The frequency of this vasovagal is immense.
Yeah.
I tell you, because you excessively stretch these back neck muscles, and patient gets vasovagal. So we started giving the cervical on the table itself. If patient at all gets vasovagal,
We can make
lie
it.
down immediately. But there should be some assistant holding head and patient, and it's like
So we have to stand up on the steps and we have to like C7 to T1.
you have to stand
So
up.
I give the 2-3 cases in the stool. So that is we publish that case.
Stand up on the stair.
Yeah, we done for the MRM, sir, but we put the catheter in downward direction and just on the study basis we did that.
Sir, one question to Dr. Rajurkar, like all these regional techniques are good, sounds to be very good, but if something goes wrong, is it approved in the court of law? Like if something goes wrong with the patient and doing under regional blocks, thyroid case, is it approved in the court of law?
It is approved, madam. Now, a lot of literature is there. If you go through literature, a lot of literature is there. They are doing thyroid surgeries and other neck surgeries or upper thoracic surgeries under cervical epidural. So I don't think there is any medical legal issues. But then, see, we are trying our maximum these techniques on these tribal patients because there are we have scarce resources, limited these things. But in our setting, in hospital setting at Nagpur, you have to select the patient. You just cannot go after every patient giving cervical epidural. Socioeconomic condition of the patient, then literacy even. Literate patient, they won't tolerate this. You have to select the patient properly for cervical epidural, for thyroid surgery. So each and every patient, you should not run after those patients for cervical epidural, for thyroid. You have to select.
So when the GA is contraindicated or maybe GA may have some issues.
In that case, you have to explain to the patient, GA, I cannot give you GA. I will try this technique. So it's this thing. But a lot of literature is there in the books. Thyroidectomy and other upper cervical surgeries or upper neck thoracic surgeries are done under cervical epidural.
There is one question about which epidural set company is good. I mean, is there any specific?
Vortex.
Yeah.
So what type of cocktail is best for patient to alleviating this patient's anxiety? Like they must be, patient may be very anxious and somebody pressing on their neck and shoulder extension itself. So what is your mixture like cocktail of that?
Routine pre-medication, we give midazolam and then fentanyl. That's all. And atropine or glyco, whatever available is with you. Routine, nothing special. But definitely patient has to be told what you are doing. So usually it is well tolerated, madam. Otherwise, cervical epidural is very patient, very painless procedure. Actually, if you go in the midline, it is quite painless. You do infiltrate with local xylox. It is a very acceptable actually this thing. It is not painful procedure, but you have to be very expertise in that, giving cervical epidural.
So there was a question, Dr. Vivek, is there an intermediate cervical block needed for that?
There is one entity of the intermediate cervical plexus block, but I mean, there is no need to go into the intermediate layer. We are getting it in the superficial layer itself. Because the same nerves are being blocked with the intermediate layer or the deep layer and the superficial layer. The only difference is in the deep and the superficial is the motor component. But there is no difference in the intermediate and the superficial layer. So, I mean, you can give superficial very safely. No need to go into the intermediate layer.
And what length of the needle you use for superficial cervical plexus block? What length? 1.5 inch or something?
It's usually depending on the patient's obesity level, but usually 1 to 1.5 inch needle is sufficient. I mean, majority of the patient we used is only 1 inch needle.
1 inch
sufficient.
And regarding catheter, Dr. Rajurkar, how long you can keep this catheter? Like
See, in cervical area, you need to keep only 2 to 3 centimeter of catheter inside, not much.
How long?
2 to 3 centimeter inside the
No,
space.
No, not long. How many days?
duration.
How many days?
48, not more than 48 hours again.
Okay,
48
duration.
hours.
Only 48 hours.
Yeah.
Okay.
Is there is a different technique? I mean,
Unmute and ask
there is
question.
one question about it. Can hemi or total thyroidectomy can be done with this cervical plexus block technique, or is there any
Yes.
change needed?
He has already answered that.
Okay.
Yeah.
Yeah, that's it. I think all the questions are finished. There are no new questions.
Anybody wants to ask question, they can unmute and ask directly. Anybody? Dr. Shilpa madam? Yes.
Yeah.
No, the madam is left.
Yeah, Shilpa ma'am write that ki GA is better, but actually the literature shows that ki if we know the expertise, when become the expertise, we can do these cases and the patient will contraindicated for the GA with the cardiac compromise, something is there and we have to do the cases. So for the expertise, I think we have to better to do the regional anesthesia in the ASA 1 and 2, and then directly we cannot able to do all these things in ASA 3 and 4. So for that, we have the knowledge and we can start before that. Just previously I told that we give the block and they give the GA, so that is not a try and error, but we have to become the expertise with the all the equipment, everything is there with the senior faculty with you, so we can do. So choice is not the GA or regional, it is the type depending on the condition area where you practice, it is on that only we can plan the plan of anesthesia.
Primary here we go most of the time post-op for post-op analgesia, and
Yeah.
they are quite comfortable when they are extubated, they are wide awake. They can have minimal discomfort, minimal breathing problem, minimal pain. They can shift themselves. They can even
Yes, yes.
their neck and all. I think
And
practice is a man perfect. That's what.
And one thing, ma'am, surgeon is always laryngeal now, so do the intubation, cord movement, com movement. That is on the table only the surgeon can ask the patient's name, so they can very happy. Oh, our laryngeal is okay from their side. So that is good advantage to a surgeon
That is a
side.
big advantage.
So always we ask the surgeon. So what is your satisfaction level, patient satisfaction level? So they are happy, we are happy. So that is also good thing. So again, do the scopy, residents are there, cords movement, no movement is in that way. It is, and always the blaming game. So better way. It is, I think I feel better that regional superficial in the thyroid nodal surgeries.
Madam.
Yes.
Good evening, madam. Injection Lehoanavir, injection ropivacaine 0.75% or bupivacaine 0.25% preservative free available in market.
Yeah.
So which drug you like to prefer? Particularly, bupivacaine is the gold standard.
Yeah.
But what is your experience? What is your opinion regarding you to
Actually,
use?
ropivacaine, we can use the ropivacaine, but I didn't use, so I not give the direct comment. We can use this. So my expertise in the 0.25. So bupivacaine, it is okay. It's not that. Only the drug is not the matter. The technique and your confidence level is very important to do these surgeries. So the drug, whatever the concentration, 10 ml superficial, 10 ml this side, and depending on the deep, we are giving that thing. So the drug is not the thing. This is better on that. Is everything is okay. The volume, patient and surgeon, all the thing together, we can do the cases with the superficial and deep cervical plexus.
If available, Livo will be ideal. Like it has got
Yes, ma'am.
and Ropio can even that.
Yeah, cardio stable. So
drugs in that case. So is there any more? If there are no more questions, Bhavesh, you the voter. Thanks.
Yeah, sure, ma'am.
Thank you.
Sir, you wanted to say something, Raju, sir?
Is anyone left?
Just a word about this cervical epidural. I am going to this Bamragad surgical camp. Now this area, Himalkasa, this Lok Biradri Prakalpa that is being run by Dr. Prakash Amte. Yeah, Padma Shri Prakash Amte. When I joined almost 22 years back, I was junior that time. And there were already a team of anesthetists doing these thyroids and other surgeries under general anesthesia. So the number of surgeries, and this camp is for only 2 days. And there were scores and hundreds of tribals sitting outside in the cold winters of January in Bhamragarh. And hardly we could do thyroid and these surgeries under general anesthesia. Then only it came to my mind, we have to devise some ways how to make fast turnover of these surgeries. Because you see, in general anesthesia, patient is taken, everything should be ready, then it is intubated, then extubated, then suction, and then shifting. Lot of time. Now you saw my that slide, three ladies sitting besides each other
in the line.
in the line. So
Between.
one patient is taken, another is taken, and then that is how actually we increase the number of surgeries in these camp settings. And to our surprise, almost all 150 patients, not cervical, these thyroid patients, but all other patients, we could finish it within the time. Otherwise, they were so unhappy going back to their village or this thing. No? So this cervical epidural has played a really a wonderful role here because that's a very remote area.
Yeah.
Dr. Maya was there last year. That's a 375 kilometers from Nagpur inside the deep jungles of Bhamragarh infested with Naxalites. And only Naxalites, they stop there these activities for those 2-3 days. Otherwise, it's a very dangerous area. And being a very remote area, no, there, there are no hospitals, nothing. Only that Hemal Kasar, Dr. Prakash Amte is offering these hospital services. And we are going every year. Last 22 years I am going. And I have introduced this cervical epidural for thyroid, breast, and the neck surgeries, upper chest surgery. That's way how we can make a fast turnover of these surgeries. And almost we finish all the surgeries. All the tribals waiting over there, we finish with surgeries.
Yeah, we have limited, time, and that's why we are
Limited
supposed
time,
to finish
limited
it.
resources, and limited
15-20
all
cases
these
in
ethics and
3-4 hours.
all those things, that doesn't work there. Because the nearest place, nearest these health facilities, almost 200 kilometers from there.
Yes.
You just can imagine, they cannot reach the hospital. And this man, Dr. Prakash Amte, he is a Padma Shri, he is doing a wonderful job over there. And what I can tell you, Dr. Maya would tell you, she was there last year. And if you wish so, you also can join this year. We are going 18th of January till 20th of January.
Yeah.
It's a 2 days
Sure,
operative.
sir. We will definitely circulate in our
Yes.
group if anybody is interested in these also.
It's a learning,
Yeah,
it's a
thank you.
learning, it's a really learning. I started
Learning.
this
Yeah, we
epidural
can try out all the, these limited resources techniques
limited
with
resources.
the positive.
So
We can learn a lot.
10,
almost
15, I suppose they might become, they get enthusiastic to do the 11th. Like if they observe for 10 people, they might go.
there is a
Yes.
scramble of anesthetists to come to
Anesthesia.
Hemal Kasa with me. But we have to, because it is again a झोपायला जागा नाही मिळत तिथे. मग we have to restrict our number of anesthetists even. Surgeons also, they restrict themselves. So I take only dozens of anesthetists from here. त्याच्यासाठी सोय करतात ते लोक बिचारे. आणि it's a great learning, great teaching. I don't go into ethics, whatever you said, no. But this works wonderfully practical, wonderfully well. And they are so tolerant, I tell you. Even if you take a cut in a conscious patient, they will not scream. They are so tough people.
Yeah, their threshold is very high. Pain threshold.
It works really well.
Okay. I think we'll go ahead with the vote of thanks. Madam, you want to say, Markandeya Madam?
No. Go on.
Okay.
The vote of thanks.
So on behalf of Society of Anesthesiologists Pimpri Chinchwad, I take this opportunity to thank our speaker, guest speaker, Dr. Rajurkar sir, our speakers, Dr. Manisha Sapate, Dr. Vivek Deshmukh, and of course, Markandeya Madam has nicely moderated the session. Vatkar Madam, Deshmukh Madam, and everybody, Paliwal sir were there, Shilpa Madam was there. So, and of course, Janeka team, providing, today we needed a lot of support from them because of the technical glitches we encountered. So thank you very much, everyone. And I declare that the session is over. So thank you sir, for the
We
nice
appreciate everyone's
interaction.
patience to
Yes,
end.
thank you. Thanks a lot.
Thank you.
Yes,
Thank
yes.
you very
Thank
much.
you, sir. Thank you, ma'am.
Good night, all.
Good
Yes,
night.
yes.
Good night.
Thank you and good night.
Thank you.
We dare, we care. Okay.
Yes.
Really appreciating for the patience of the all listeners to wait till the end, because
Yes.
the session was interesting. Of course, it is not the routine 1+1. We learned a lot from this session. Thank you with all the speakers. Yeah. Thank you.
Yes, ma'am. Thank you, ma'am. Thanks a lot.
Thank you.